The thoracic spine consists of 12 segments, and normally it presents with a posterior convexity, the thoracic kyphosis. The vertebral bodies are heart-shaped, have intervertebral discs in between. The posterior arches, with their spinous processes and transverse processes, also have the facet joints. Now, the shape of the facet joints is basically, they will be facing backward and a little bit lateral on the superior side. They're more vertically oriented. The thoracic spine also presents interesting anatomy as it relates to the attachment of the ribs. We have the demifacets on each side of an intervertebral disc space, an inferior demifacet of one vertebra superior with the other, and the intervening disc space, which provides for the attachment of the rib head, the costovertebral articulation. The transverse processes have on their anterior surfaces a facet joint also that articulates with the rib, called the costotransverse articulation. So between the costovertebral and the costotransverse articulations, they control a lot of rib motion. Now, the attachment of the ribs in these locations also reduces the amount of motion available in the thoracic spine. The thoracic spine does have the capacity of flexion, extension, side bending right and left, and the usual coupled rotation right and left. In the thoracic spine, we have coupling behavior of the neutral type, neutral mechanics. When the thoracic kyphus is present, side bending to one side rotates to the other. And depending upon where you are in the thoracic kyphosis, you can have side bending and rotation to couple to the same side, or the non-neutral behavior, and that can occur in both flexion and extension. So that we can have non-neutral coupling of rotation and side bending to the same side, or in neutral mechanics, side bending and rotation to opposite sides. We have three dysfunctions that can occur within the thoracic spine. The first would be the neutral group dysfunction, wherein we would have 3 or more thoracic vertebrae included. There would be no significant flexion or extension restriction. The group would be side bent one way, rotated the other. In this example, side bent right, rotated left. And it would be restricted in that position. The motion restriction would be left side bending and right rotation. The non-neutral dysfunctions occur when the behavior of one vertebral motion segment, one thoracic vertebra on the other, becomes altered, and it behaves as though something interferes with facet maneuvers, facet motion. If, for example, something interferes with the left facet opening, it is closed and stuck there for some reason. It will interfere with the capacity of the vertebra to forward bend, to side bend to the right, and have the accompanying right rotation. Positionally, it will be extended, side bent, rotated left, and held in that position with the left facet being restricted in a closed or extended position. The other non-neutral possibility would be if the right facet would not close for some reason. That would restrict the capacity of the superior vertebra on the inferior of going into extension, right side bending, and the accompanying right rotation. Positionally, it would be flexed, side bent left, rotated left, and the right facet joint would be restricted in a flexed or open position. From the structural diagnostic perspective, we can evaluate for these three different dysfunctions by the behavior of the transverse processes as we evaluate our patient in the forward bent position, the neutral position, and backward bent position. And as we follow the behavior of these transverse processes, we will know whether we have a non-neutral dysfunction in which a facet will not open, or one in which the facet will not close, or we have a group of dysfunctions, a group of segments that are dysfunctional, 3 or more on one side. We will palpate then transverse processes. We will follow them through forward bending, backward bending, evaluate them in neutral, and relate that to tissue texture abnormality that we will palpate through the medial groove of the longismus muscle, which overlies, that medial groove overlies the facet joints, and deep in that groove are the multifidi and rotatories and the levator costalis in the thoracic region, those deep fourth layer muscles. If they are palpably hypertonic, you can be sure there is dysfunction at that level. The structural diagnostic process for the thoracic spine is done in two parts. We will examine the upper thoracic spine with the patient sitting on the table, and we'll use active forward bending and backward bending of the head to introduce flexion and extension throughout the thoracic spine. For the lower thoracic spine, we will put the patient in 3 different positions to evaluate from about T6 down to the lower thoracic spine, and we will do that in a similar fashion that we do for the lumbar spine, although we're going to be focusing on the lower thoracic segments from about 5-6 down to the thoracolumbar junction. We're particularly interested to begin the process by palpating for muscle hypertonicity in the groove medial to the longismus and just lateral to the spinous process. I like to take my 2 fingers and pull them down in that groove in a symmetrical fashion. It gives me the opportunity to feel for tissue texture abnormalities of drag of the skin or changes in the skin itself, but I can also sense deeply to see if I can find muscle hypertonicity in one of the deep fourth layer muscles. Normally that groove should not show you a little short muscle tension. If you feel it in there, then you can be sure there is dysfunction at that level. Now we will also want to use the transverse processes as our landmark to follow motion and infer the capability of flexion, extension, side bending, and rotation to opposite sides and to the same side. In the upper thoracic spine, the transverse processes are approached from the lateral aspect of the longismus, and we will go anteriorly and medially through the tissues until we can come down onto a transverse process and relate that to the one above and the one below. Now in the thoracic spine, the widest transverse processes are at T1, and as you go down the thoracic column, the transverse processes become more and more medial until by the time you get to T12, they're very close to the midline. We can start by identifying a level that is tissue texture reaction, or in which we find in a screening fashion that one transverse process is more posterior than the other. This is the spinous process of T1, 2, 3, 4, 5 on down. For the upper 5 to 6, we can do the motion testing as follows. Here I find the transverse processes of 4 to be quite symmetrical. The transverse processes of 4 are quite symmetrical. I'm going to ask him to look down at the floor, up at the ceiling, and straight ahead. Both transverse processes, with my thumbs on them, seem to move symmetrically forward and symmetrically backward. Now the segment above, which is 3, in neutral, I have a sense that this transverse process on the right side is posterior, inferring that the segment is rotated to the right. Now let's see how it behaves in motion testing. look down at the floor, and as he moves his head into flexion, I feel the left transverse process going cephalward and anteriorly while the right one stays posterior where it was. Look up at the ceiling. Keep going. That's good. And straight. When he comes into backward bending, I feel this left transverse process come back and match the one on the right side. So something is preventing the right side of this segment moving forward. Do it again for us, Mark. Look down at the floor. This is the moving side. The left transverse process does go forward. This one is held backward. Look up at the ceiling. And straight. When it's fully backward bent, it's symmetrical. In neutral, it's posterior right, and in forward bending, it's even more posterior right. That tells us that the right facet does not open fully during forward bending, restricts flexion, restricts left side bending, and we can infer that it will restrict left rotation as well. Because we know that when he comes into backward bending, they both become symmetrical, therefore both facets have closed symmetrically. We have a segment that is extended, right side bent, right rotated. It resists forward bending, left side bending, and left rotation. The right facet does not open from the functional perspective. Now, as we go above that segment, we find that there continues to be a little fullness at 2 as well. So that segment probably is included in a little short group dysfunction above that non-neutral extended right side bent, right rotated segment here, and that's very common. So we have a non-neutral dysfunction here and a short group of neutral dysfunction above. Structural diagnosis of the mid and lower thoracic spine can be accomplished in 2 ways. One, a dynamic testing process similar to what we did in the upper thoracic spine, or in 3 positions of forward bending, neutral, and backward bending, identifying the behavior of transverse processes during those 3 positions. We will start by just palpating over the medial groove of the longissimus, palpating for deep muscle hypertonicity or any change in skin drag or other tissue characteristics. We'll also palpate to see if we can feel any fullness in the region of the transverse processes. And we have a sense of some fullness in this mid to lower thoracic region on the right side. We will start from below upward to evaluate from T12, which I've marked here for us, up until we see what's going on in this area of fullness on the right side. We'll start with our thumbs, again, on transverse processes, and remember that T12, the transverse processes, are the closest to the midline of any of the thoracic transverse processes. Then we'll have our patient bend forward, and forward mark, and we'll start with 12. That looks level. 11, 10, 9. But when we get to 8, we find that the transverse process is posterior on the right side. So is 7, and a little bit at 6. Come on back up. So we know we have some difficulty right here at 8, 7, and 6. But we knew that 9 was fairly level. So we'll identify 9, use that as our reference point. My thumbs there appear to be symmetrical. At 8, it's posterior on the right side. Now let's find its behavior. Bend forward for us. It stays posterior on the right throughout that arc. Come on back up. Stick your belly out and look up at the ceiling. In backward bending, the thumbs become symmetrical. Relax to neutral. Let's do that again to confirm it. And forward, posterior on the right, and forward bending. Come back. Look up at the ceiling, and in backward bending it is symmetrical. Relax. We know then that T8 on T9 has restriction on this right side in that during forward bending, this transverse process stayed posterior while the one on the left side had the capacity to move forward as the left facet was flexing. This restriction on the right side is that the right facet appears to be restricted in a closed position or extended and resists forward bending, left side bending, and left rotation. Positionally, T8 on T9 is extended, right side bent, and right rotated. The motion restriction is forward bending, left side bending, and left rotation. It would appear that the 2 or 3 segments just above that are in a group dysfunction, convex to the right, wherein those segments are rotated right and side bent left. We won't really know that, however, until we treat the T8, T9 dysfunction and reevaluate in this area. So we have looked for symmetry, tissue reaction, and motion behavior of the lower thoracic spine by this process so far. Now we will proceed to put him on the table and examine this area prone and in the backward bent position statically. We are now evaluating the lower thoracic spine in the prone position. This is neutral. We will start from 12, level at 12, 11, 10, 9. When we get to 8, he's posterior on the right side of 8. So we know that T8 is rotated right in relation to T9. Now let's find out what happens in backward bending. Go up on your elbows, chin in your hands, and then when he does that, it appears that the transverse processes are more level. In other words, the 2 facets on each side now are symmetrically in a closed position. Statically, 12, 11, 10, 9, 8, even 7, in the backward bent position, all appear to be quite level. Down flat, reevaluating in that prone position, T8 is posterior, and he still has this small amount of fullness, which is probably the reactive rotation of the segments above to the dysfunction at T8, T9. Having made that diagnosis, we would have to proceed to treat T8 and then reevaluate our thoracic spine to see if we would need to do other things within it, either a group dysfunction or perhaps other non-neutral dysfunctions. A muscle energy treatment for a single segment non-neutral dysfunction in the upper thoracic spine is done in the following fashion. On our patient Mark, we observed that the right transverse process of T4 was posterior in comparison to 5, and that in forward bending it became more prominent, and in backward bending it became more symmetrical. We arrived at a diagnosis that the right facet, for some reason or other, was unable to fully flex and open. The motion restriction of the segment was flexion, left side bending, and left rotation. Positionally, it was extended, right side bent, and right rotated. Our procedure then will attempt to take T4 on 5, put it into flexion, left side bending, and left rotation to open the facet on the right side, restoring its functional capacity to be symmetrical with the one on the opposite side. To do that on our patient, we have identified for you the transverse process of T4, and this is the restricted facet joint. I start by monitoring the interspace between T4 and T5 at the interspinous space, and one monitoring finger over that posterior transverse process of 4. The first thing I want to do is introduce forward bending. I'll do that by having him lean back against me, starting from a translation from forward backward, and as I let his head drop forward and translate him backward, I can feel flexion at the segment I want. In other words, we're taking up flexion from above, flexion from below, localized right to this finger at the interspinous space. When I reach the first flexion barrier, then I'm going to introduce left side bending and the coupled left rotation, and I do that by translating with my body, taking mark from left to right in this fashion, holding his head stable, but that introduces left side bending, and I let the left rotation follow. I don't put a lot of left rotation in consciously, I let it follow the side bending. So I now have engaged the barriers of flexion, left side bending, and left rotation. Now I'm going to ask him to use a muscle effort to have the muscles of extension and right side bending contract, and particularly focusing at the deep muscle overlying that facet joint. I'll do that by asking him, take your head backward over your right shoulder. Not too hard, Mark, not too hard. Steady and relax. That's a combined extension right side bending effort. Mass action of a number of muscles, but I can also palpate under this finger the behavior of the muscle at the segmental level. I should feel that contract. Fine tune it again. One more time, backward over the right shoulder, and relax. If I want just a pure side bending effort, I will say, Mark, take your right ear to your right shoulder, just side bending. Relax. We use side bending or a flexion extension effort more than we do any rotation because they're easier to control. All right, one last time. Mark backward over that right shoulder. Stop. Relax. Stretch the last time, then straighten the patient up into neutral. Straighten right up. And then we're prepared to reevaluate the behavior of T4 on T5. Look down at the floor. Look up at the ceiling. Down at the floor. Up at the ceiling. And straight ahead. Now we find that T4 transverse processes appear to be moving symmetrically forward and backward. We still seem to have some fullness above T4 on this right side. I've marked that with that original fullness we saw before. Now what we'll need to do is see what 3 is doing in relation to 4. Look down at the floor, up at the ceiling, straight ahead. 2, look down at the floor, up to the ceiling, straight ahead. It appears that they stay relatively posterior throughout the arc. Not an unusual finding. This tells us we still have a short group restriction that is convex to the right. It is side bent left, rotated right, resists right side bending and left rotation. We will need to treat that pathology before we can proceed on with our additional evaluation of the thoracic spine. We have identified that Mark still has a short 3-segment group dysfunction of T1, 2, and 3 above T4 here, that even after restoring function here, we still have this fullness. So now we want to give a muscle energy procedure which will introduce right side bending and left rotation of that group in this fashion. We will begin that by placing my thumb at the intertransverse space between T2 and T3 on the right side. So my thumb is at the interspace between the transverse processes on the right side, between 2 and 3. This arm is going to control his head and neck, and I do that by putting my forearm against the side of his neck and head, my hand over the top, so I can control his head and neck, but protect the neck so I'm not moving it and using it as a loose lever arm. With the patient in neutral, sit nice and tall, no flexion or extension. Remember, this is a group dysfunction. The thumb at the intertransverse space with a vector of force going anterior and a little bit medial. We will introduce right side bending and left rotation from above, translate his whole body a little bit to the left from the right until we feel the first restrictive barrier. The instruction to the patient will now be, tip your left ear toward your left shoulder. Tip left, stop, relax, take up a little more slack of side bending and rotation. Tip your left ear left, stop. I'm maintaining the force on the thumb anteriorly and medially at that interspace, causing it to side bend to the right there, localized there. Now, tip your left ear left one more time, and relax, and stretch. We're constantly stretching out this concavity on the left side. Now let's see what that does to our upper thoracic group. Look down at the floor. They're more symmetrical. Look straight. And look up at the ceiling. Look straight ahead. That fullness is not as obvious to me as it was before. Still a little fullness left there, but it's clearly better than it was. We have made change. That's our objective. We can now proceed on to evaluate the rest of the thoracic spine to see if we have any more dysfunctions. A non-neutral dysfunction in the upper thoracic spine in which the facet is held open or flexed and restricted there is what we call the FRS dysfunction, FRS to the right. The segment is flexed, side bent, and rotated to the right. The motion restriction is extension, left side bending, and left rotation because this facet does not close. Diagnostically, you would find that in evaluating the two transverse processes of T4 on T5, in full forward bending they'd be symmetrical, but in backward bending we would find our dysfunction, in that this transverse process would continue backward to us on the right side during trunk extension and neck extension. We would then make a diagnosis that the left facet did not close. Our procedure would be to introduce extension, left side bending, and left rotation to close the facet on the left side. Now, Mark does not have that particular pathology, but I will simulate how that would be done. T4 on 5, 4 is flexed, side bent, rotated right on 5. We will monitor with an index finger at the interspace of 4 on 5 for our extension barrier, and I will put another monitoring finger over the left transverse process of 4 so that I can feel it rotate to the left as I introduce that motion. This arm will control his head and neck, protecting the head and neck and using it as a lever arm. We start by just initiating just a little rotation left, and from there we'll ask him to tuck his chin in just a little bit to protect that neck. Now with my thumb down low in his thoracic spine, I can ask him, stick your belly forward just a little bit there. And as he does that, we're translating him from behind forward, introducing extension. We fine-tune that extension with his head and neck, keeping his chin tucked in. When we feel the first extension barrier under the index finger, we then side bend him and rotate him left. Notice I let him translate from left to right so that our left side bending is localized at this segment right here. When we engage the extension and left side bending, left rotational barrier, we ask him to take his right ear to his right shoulder. Push right. That's a right side bending effort. Stop. Relax. A little more extension. A little more side bending, rotation left. Gently. Now tip your right ear to the right again. Relax. Fine-tune extension and side bending. Just notice how those are just small increments of motion. Tip your right ear to the right shoulder again. Relax. Another instruction we could give our patient and resist it with my hand on the top of his head would be tip your head forward. A flexion effort, and we resist that. And stop. 3 to 5 repetitions, 3 to 5 seconds. Then we return him back to neutral and would reevaluate to see if we had restored extension capability to that left facet. In evaluation of Mark's lower thoracic spine, we found dysfunction at T8 on T9, in which we found the right transverse process prominent in neutral. It got worse in forward bending, and it became symmetrical in backward bending. So we knew that he had restriction of the right facet on 8 to 9. The right facet would not open. The T8 on T9 was extended, right side bent, right rotated. Its motion restriction was flexion, side bending, and rotation to the left. So our muscle energy procedure for T8 on 9 will introduce forward bending, left side bending, and left rotation using muscle energy activating forces, attempting to open the facet on the right side at T8, 9. The muscle energy procedures in the lower thoracic spine are different from those of the upper thoracic spine in that we will need to control the patient's shoulders for trunk control rather than the head and neck. Mark has an ERS dysfunction to the right at T8 on 9. This transverse process we found was posterior. The first thing we'll need to do is to control his trunk, and I'll do that by asking him to take his left hand and hold his right shoulder. Then I will reach over the top of his left shoulder and grab the right one so that I can control his trunk into side bending left and rotation left very easily. Having done that, I will identify the T8-9 interspace and the transverse process of 8 and ask Mark if he will just slump a little bit with his back into my finger. Whoa, come up just a little. That's a little slump, right there. That's the first flexion restriction. Now I'm going to introduce left side bending and left rotation by translating him from left to right a little bit, right there. That coupled side bending and rotation go together. Now I'm going to ask him to tip his right shoulder to the right. Lean right with your right shoulder, and I resist that. Stop. Fine-tune a little more flexion by a little more slump, a little more side bending and rotation left. Take that right shoulder to the right again. Lean right. I should feel contraction of the deep muscle right there. Relax. Fine-tune the flexion, side bending and rotation left, keeping this at the apex of the convexity I've introduced for left side bending. Now, lean to the right one more time. Stop. Relax. Now I return him back to neutral. and can now reevaluate the behavior of 8 on 9. On re-examining our patient, we find that we have been able to restore function to T8 on T9, but we still have fullness above that T8 level involving the transverse processes of 5, 6, and 7 particularly. So we have a short group, neutral group dysfunction that is side bent to the left, rotated to the right, persists in all directions of forward bending, neutral, and backward bending. So what we want to do is to introduce a muscle energy procedure which will now side bend it to the right and rotate it left and stretch out the concavity which is present on the left side. To do that on our patient, we need to be able to control his trunk in neutral mechanics. And we will do that by asking him again to grasp his right shoulder with his left hand. But now this time I will slide my arm under his left axilla over to the right shoulder, giving me the capacity to side bend him right and rotate him left and control his trunk. Having control of his upper trunk, I take him into neutral mechanics. I will put my thumb at the interspace between the transverse processes of 6 and 7, at the intertransverse space, with the vector of my thumb going anteriorly and a little bit medially to localize my right side bending effort that I want to do at that segment. By keeping him in neutral, I will then introduce right side bending. Note the translation from right to left, localizing it at my thumb, and left rotation to the barrier. At that point, I will ask him to give me a left side bending effort. Lean to the left with your left shoulder. I hold that, stop, that's an isometric effort, fine-tune side bending and rotation, maintaining neutral mechanics of flexion and extension, lean left again, and stop. Fine-tune, lean left again, and relax. Notice how we have localized right to the 6-7 area our side bending to the right. All the time we have stretched this concavity on the left side with each of his efforts attempting to left side bend. Now let's see. The fullness is clearly less prominent on the right side than it was before, so that we have restored normal function to this group above the T8 pathology with which we started. Another dysfunction in the lower thoracic spine which we can encounter is that in which we have non-neutral dysfunction of one segment in which a facet does not close. Mark does not happen to have this, but we will simulate as though his left facet at T8-9 has lost its capacity to close. We would have found that by the asymmetry of the transverse processes of 8 versus 9, the right would be posterior in neutral. It would have gotten symmetrical in forward bending, but the farther we backward bent the patient, the more we would find the right transverse process coming posteriorly. We would then know that this left facet did not close physiologically. The segment then would have positioned itself in a flexed, right side bent, right rotated position. It would have extension, left side bending, and left rotation restriction. Our technique then will be designed to close this left facet by introducing extension, left side bending, and left rotation, and wind up with closure of the left facet. To do that, we will start by, I will sit down behind the patient, and identify the interspinous space between 8 and 9 with one finger, and the transverse process on the left side of T8. And I will have him stay in neutral, sit nice and tall. I control his left shoulder, and the first step of this procedure will be to initiate left rotation of T8 to enhance my capacity to close this facet on the left side that we have to do. To accomplish that, we're going to use neutral mechanics to begin. Now, what I want you to do, Mark, is just gently drop your right shoulder down and shift your weight to your left buttock a little bit. Now I've got him the right side bent, and I can left rotate him a little bit. I have control of his upper trunk with my left hand. Now lean left into my hand. Lean your left shoulder. Relax. This whole step is only to get left rotation of T8. Push again left. Stop. Push left again. Stop. Now when I've got that rotation, now I want to introduce extension and left side bending. Now this will be a combined maneuver, what I will do and the instructions given to the patient. All right, Mark, what I want you to do when I tell you to is to shift your weight back to your right buttock and stick your belly out over your right knee. All right, go. And as he does that, I side bend him left. Don't lean back on me, Mark. Stay upright, just your belly out over the knee. Very good. Inner space there, transverse process there. Now lift this toward the ceiling. Lift the left shoulder to the ceiling. That's a right side bending effort. We resist that. Stop. Belly out over your knee a little more. That's more extension. I come down with more left side bending. Left knee to the left shoulder to the ceiling. Left shoulder to the ceiling. And stop. Stick your belly out over. One more time. And stop. Now we complete the procedure by closing both facets symmetrically. I block 9 from below, stand up, reach across, grab his chest wall, square him up, and resist forward bending. Lean forward into my arm. And stop. We now have closed both facets into symmetrical backward bending. A high-velocity thrusting procedure for a non-neutral dysfunction in the thoracic spine that is flexed, side bent, and rotated right, in which the left facet does not close. The motion restriction of the segment is extension, left side bending, and left rotation. We can use what is termed the cross pisiform thrust procedure, in which I will put the pisiform of my left hand on the right transverse process in order to introduce a force anteriorly to rotate 8 to the left. My right pisiform will be on the superior aspect of the transverse process of 8, and I will move that in a caudad direction in order to introduce left side bending. So as I introduce left rotation here and left side bending there and move toward the table, I will introduce extension, and we will deal with all 3 components of our dysfunction. On our patient, we have identified the transverse processes of T8. My left pisiform goes on the right transverse process, and my vector of force will be straight to the table to introduce left rotation. My right pisiform will go on the superior aspect of the left transverse process, and I will take it caudad. I will take up the slack of both of those directed toward the table. When I take up all of that slack, then it is just a thrust to the table, introducing extension and exaggerating the left side bending and the left rotation. Again, we will reevaluate to see if we have restored function to that dysfunctional left facet. Supine high velocity technique requires the performance of three basic principles. They start with the establishment of a fulcrum to hold the inferior segment of our vertebral motion segment that is dysfunctional. We will use a hand in several different ways to do that. For example, in the lower thoracic region, if I wanted to treat T7 on T8, I would want to hold 8 and move 7 on it. To do that, I have to establish a fulcrum on 8. I can do that by laying my hand across and holding the transverse processes of 8 with the metacarpal phalangeal joint of my thumb on one side and the metacarpal phalangeal joint of my index finger on the other. Or I can fold all of my knuckles in together and lay them on the patient's right side with my thumb along the left side. Or the one that I prefer is to flex the index finger and flex the index finger and use it in conjunction with the metacarpal phalangeal joint of the thumb, because I can be very precise with the localization on the transverse process. Now let's see that on our patient. We will identify the dysfunctional segment, find the lower segment of that, and lay our hand across in that fashion. Make all of our fingers together in that fashion. Or the one I prefer is to flex that index finger, put it together with the thumb, and place it right on the transverse processes. Notice that in each of these hand positions, my thumb is laying along the side of the spinous process of the vertebra above the one I'm holding. Therefore, I can monitor motion to the upper segments when I go through the rest of the treatment procedure. The second principle in the supine high velocity procedure is the establishment of the lever arm. And we're going to do that by crossing our patient's arms across in front and having him hold the shoulder so that I have now a lever arm where I can control the trunk through these two elbows. Notice that when I created that lever arm, that I put the arm opposite me above the other one in this fashion, rather than having it cross over with the arm away from me being lower. The reason for that is you lose the capacity to control the chest wall that direction, whereas here, now you have good control of the trunk. Occasionally in the upper thoracic spine, we will want to identify our lever arm by having him hold his opposite shoulder and then put his hand there. Now I can get higher in the thoracic spine and still control down to the fulcrum, which I will put underneath the patient's thoracic spine at the appropriate time. The third principle is that after once establishing the lever arm, we will roll the patient to us to appropriately place the fulcrum on the inferior vertebra of the motion segment. Now it is important that we take the patient back to the midline before we introduce any other motion, and that we identify the lever arm and the force through my body on it so that it is at the fulcrum. It will not be above it, it will not be below it, but it will be at the fulcrum placed underneath the patient. From this position, then depending upon what I do with the trunk above, either with the shoulders or the head, I can deal with neutral or non-neutral dysfunctions of the thoracic spine with a supine high-velocity technique procedure. It is important that you understand these three principles of the fulcrum, lever arm, and the relationship of those to each other in the midline in order to proceed on with high-velocity supine technique in the thoracic spine. A high-velocity, low-amplitude thrust technique for a dysfunction at T4 on T5, in which T4 is extended, right side bent, and right rotated. The right facet is restricted in a closed position. The motion restriction being flexion, left side bending, and left rotation will be accomplished by the following procedure. We will establish our fulcrum on T5 so that we have a contact on each transverse process, stabilizing T5. Then we will flex the head and upper trunk and side bend and rotate it to the left until we reach the barrier. At that point, we will put a thrust from our lever arm to our fulcrum, which winds up with an acute opening of the right facet between T4 on T5. Let us see how this would appear on our patient. We start by establishing our lever arm, bringing the right arm over the left. We now can control the trunk. I now will roll him to me and establish our fulcrum on T5. I will then take him back to the midline and localize my lever arm to that fulcrum before I move anything above. At that point, I now will flex him, left side bend him, and left rotate him, and take up all of the slack. And then when I have engaged the flexion, left side bending, left rotational restriction, I put a thrust through the lever arm to the fulcrum. Again, we would go back and reevaluate to see if we have restored function. Let me review that one more time. We want to provide a technique which will open the facet on the right side between T4 on T5. We established our lever arm to give us control of the upper trunk. I rolled him to me and put a contact point, my fulcrum, on T5, went back to the midline, so I was stabilized at midline with the force through the lever arm to the fulcrum. From there, I introduced flexion, left side bending, left rotation, took up the slack, and with a body thrust through my epigastrium to the lever arm, we put a thrust quickly through toward the table. A high-velocity, low-amplitude thrust procedure for a group dysfunction is accomplished in the following fashion. Mark has a group dysfunction from T8 to T5, where in that group of 4 segments is side bent to the left and rotated to the right. We have a series of 4 transverse processes that are more posterior than the ones above and below. We start by putting a fulcrum on those transverse processes, and we will use the whole thenar eminence and the thumb along those most posterior transverse processes, focusing the metacarpophalangeal joint of our thumb at approximately the apex of the group. Then when we establish our lever arm, we will localize it to that fulcrum and establish from above trunk's motion of right side bending and left rotation. And we'll keep the flexion extension in neutral, the thrust will then go through the lever arm to our thumb on those posterior transverse processes. The end result is we rotate the whole group into left rotation. Now let us see how that would look on our patient. We establish our lever arm, roll the patient to us. There's 5. From 5, 6, 7, and 8. We'll put the thumb and thenar remnants along those posterior transverse processes, take him back to the midline, localize our lever arm to that fulcrum. By controlling his head, there will only be enough flexion or extension to keep him in neutral. Then I will side bend him to the right, rotate him to the left, hold it in neutral with the side bending right, rotation left. The thrust will be an epigastric thrust through the lever arm to the fulcrum in that fashion. Obviously, you would go back and reevaluate again to see if it had been restored to function. Let us do that for you again. We have a group dysfunction from 5 to 8, side bent left, rotated right. After establishing our lever arm, we come and put our thumb and thenar remnants along those most transverse processes, taking back to the midline, localize our lever arm to the fulcrum. Have flexion or extension sufficient to keep him in neutral, side bend him to that side, which is right side bending, rotate to the left, take up all of the slack through the lever arm to the fulcrum, breath in, Mark, and out, that helps him relax, a thrust to the fulcrum with the epigastrium. The end result is, with our thumb on the transverse processes, they rotate then to the left. In the lower thoracic spine, there are dysfunctions in which there is bilateral restriction of both facet joints. This only occurs occasionally and is more common in the lower thoracic spine. Occasionally you will find bilateral extension of the facet joints, and it will be extended and held there. We will know that dysfunction is present because we will have bilateral hypertonic muscle at that level, and during forward bending and backward bending, the spinous processes stay symmetrical throughout that arc, but the interspinous space does not open during flexion as it should. So it moves as a sort of block, and this is relatively easily visible when you ask the patient to trunk forward bend. The spinous processes do not open. What we will want to do then is to control the bottom vertebra, take the top one into the flexion restriction barrier, and put a thrust which will wind up opening the facets bilaterally. On our patient, it would look like this. Once again, we establish our lever arm. Now we will roll him to us, identify our dysfunctional segment, localize to the bottom vertebra, back to the midline. Now I will flex him, pure flexion, until we are localized to the dysfunctional segment. My lever arm now takes its direction to the fulcrum, and as I keep his trunk flexed and thrust to the table, I wind up with an opening of both facets at that segment. Let me review that again for you. We want to open two facets simultaneously. We establish our lever arm, roll the patient to us, identify our segmental level, put a fulcrum on the bottom segment, back to the midline. Everything is now mid-plane. We flex his head, trunk, down to that level, and while maintaining it in the flexed position, we put a straight epigastric thrust through our lever arm to the fulcrum, straight down. Again, we would go back and reevaluate had we accomplished our task of opening those facets and having that interspinous space open during forward bending. It is possible in a lower thoracic spine to have bilateral restriction of a facet joint in which both facets are held in an open position or flexed and resist extension, so that we wind up with bilateral extension restriction. The segment is bilaterally flexed. What we want to do is establish a high velocity procedure which will stabilize the bottom segment with our fulcrum, take the trunk above, flex down from above, take the trunk and flex down from above, then start and let the trunk go into extension, and as soon as it begins to get just past our fulcrum, we will then have a thrust through our lever arm in a vector of force just over our fulcrum, which results in closure bilaterally of the two facet joints. Let's see what that would look like on our patient. We start by establishing our lever arm. We'll roll him to me, identify the lower segment, put our fulcrum there, back to the midline. I now will flex him past that segment, and as I start to take him into extension, as soon as I'm above the fulcrum, the thrust goes with the epigastrium in a vector just above the fulcrum, resulting in closure of the two facets bilaterally. Let's review that so you see the difference between that one and the previous technique of opening those two facets. Establish our lever arm, establish our fulcrum, back to the midline, flex the trunk past the fulcrum, then start it into extension. As soon as we get past the fulcrum, we put a thrust in through the epigastrium in a plane just over our fulcrum to close the facets. In the lower thoracic spine, where these bilateral flexion and extension restrictions are present most commonly, occasionally in some people it's useful to use a different lever arm. That we establish by having our patient grasp their two hands together behind the neck. Then by pulling the elbows together, I have a lever arm that I can roll to me, establish my fulcrum, and then I can control that flexion extension through the two arms holding his head and trunk. Notice how that controls flexion, past flexion, drop it back into extension. The thrust still goes through the two arms as your lever arm. Remember, on all of these techniques, after you do them, go back and re-examine your patient to see if you've accomplished your task. In summary, in the thoracic spine, we have defined for you the 12 thoracic vertebrae and their unique anatomy, particularly that as it relates to the rib cage. We identified that it was possible to have 3 different dysfunctions in the thoracic spine: an ERS dysfunction which resisted flexion, side bending, and rotation to the opposite side, an FRS dysfunction in which it resisted extension, side bending, and rotation to the opposite side, the first being a facet that didn't open, the second being a facet that didn't close. And we identified a group dysfunction with side bending and rotation to the opposite side. The diagnostic process in the upper thoracic segments was done by following the transverse processes through a flexion extension arc of the head and upper trunk by active motion of the patient of nodding the head forward and then backward. In the lower thoracic region, from a 6 down to T12, we did that both dynamically by following transverse processes and forward bending, backward bending, and we did it in 3 positions. We looked at the relative position of the transverse processes when fully flexed, in neutral, and in fully extended. Then we provided for you muscle energy procedures for both the upper group and lower group for all 3 dysfunctions, and focused upon the principles of localization. Primarily we used translation from before backward to localize to a flexion barrier. We did translation from behind forward to localize to an extension barrier. And then we translated from left to right to introduce side bending left, translated from right to left to localized for side bending right. The sequence was we did either the flexion or extension first, introduced the translation, and let the rotation follow. In the upper thoracic segments for muscle energy, we protected the head and neck and used it as a lever arm for our muscle energy activity. For the lower group, we used differences in hand position engaging both shoulders. For the high velocity procedures, the supine ones particularly, we focused on the 3 principles of establishing a fulcrum, establishing a lever arm by crossing the arms, and then having a compressive force with the epigastrium against the lever arm localized to the fulcrum, and then we would maneuver the trunk above that in directions necessary to accomplish the restoration of function at our dysfunctional segment. We provided you one for an ERS dysfunction to the right, where we flexed, side bent, rotated left. We did one that had a group dysfunction convex to the right, and we side bent it left and rotated it, side bent it right rather, and rotated it left. We did one prone high velocity technique that is useful only for extension restriction. It requires precision in contacting the 2 transverse processes so that you could control rotation with contact on one transverse process and side bending with contact on the other. The 2 contacts together could take the segment into extension and overcome the extension restriction. As in all cautions of all techniques of this nature, after you do them, go back and re-examine your patient to see if you have been successful.